You know, something else about a cash practice philosophy and the idea behind what we're doing, what this does is it allows the doctor to determine what the patient's needs are or what the patient needs for treatment. You know, very often when I'm talking with doctors, they say, you know, I've been involved with this insurance stuff for a long time, and we get great results when we're allowed to do what we want to do. But the problem is, based on the insurance model, in many cases, you know what happens? As they start to get somebody better, they have to stop care, they have to send off their notes, and they have to ask permission from some nurse in Idaho who doesn't know the patient, who doesn't care about the patient, and who certainly doesn't care about what the patient's results are. They've never met the patient. They don't have any kind of a relationship with the patient. Along with this, from just a philosophy standpoint, you know, something I don't want to be is another doctor in the long list of doctors that the patient's gone to see. You know, as far as patients are concerned, the interesting things that we see, I told you earlier that I have patients that come to me and they say, you know what, I went to see my regular chiropractor until it got so bad I realized that this wasn't a regular chiropractic problem. But what happens is that wasn't just one chiropractor that they've seen. In many cases, they've seen 1 to 5 chiropractors. Okay, they've had epidural injections, cortisone injections, physical therapy, and they've been to 1 to 5 surgeons. Okay, they may have had surgery between 1 and 15 times. But those are the list of the doctors that they've seen. It's almost like the graveyard of doctors that they've been through. Okay, and once you start to go back and look at all those different headstones that they've actually been to see, okay, those people are kind of dead in that patient's mind because they weren't able to help them. And when we start to understand how important what it is that we do, when we start to understand what we're doing here and how that can actually form the patient's not only reality, but also their concept of what direction they're going, what they want to be able to be, do, and have. This becomes a very important thing. Also, along with that, this does help psychologically get the patient moved into a situation where they're actually expecting better results. Once they believe that they're going to get better, they're going to start to expect it. Along with this, we're actually helping to plant more or less a placebo in the patient's mind. Okay, so we've got them invested in it. We've got them motivated. We talked about the placebo a little bit, but we're actually implanting that placebo because you know what? One of the things that we talk about when the patients are released from their initial consultation, you know, it's a great thing that Dr. Bush gave you that book because if he feels he's going to be able to help you, or he wouldn't have given you that book if he didn't feel he was going to be able to help you. And Dr. Bush only accepts patients that he feels he's going to be able to have a significant amount of effect on and a significant amount of benefit for. And along with that, we also can control the patient's outcomes better. You know, when you start looking at a patient and you realize that you can actually have some benefits for some things that they never thought that they were going to be able to get well before, it's a pretty amazing thing. Along with that, you know, some of the other things you don't have to worry about, and we're going to go over a list of these things in just a minute, but, you know, we do have better control. You know, as far as reports and reporting and things like that, this is something that doesn't necessarily belong in the philosophy of cash practice, but as far as reports are concerned, I hadn't written a report for the first, I think, 6 or 8 years I was in practice. And then I got this idea that I was going to become a really great personal injury chiropractor, okay? And we were doing fantastic with what we were doing. We're having great results with the DRS program. We're having great results with our chiropractic patients. We're doing everything on a cash basis. And I got this idea because I heard some people were doing really well with it. And this is where I started thinking from a financial standpoint as opposed to from an outcome and a result standpoint. And I started looking at it, well, you know, we could make a lot more money if we're just seeing these patients because we can get it all from the insurance companies really easy that way, right? The funniest thing about this is within the first couple of months of treating patients like that, we started seeing a lot of patients that were personal injury. At the same time, then I had to start writing all these reports. I hadn't written a report since I was in school. And I'll tell you what, I didn't like them then. And I damn sure don't like them now. And the funny thing about it was, we actually had to go through that for me to realize that I was making a huge mistake And when you use money as a motivating factor, it does change what you're actually doing. It changes not only the decisions that you make, but the outcomes that you're going to have in the long run. And so that's something that we have to look at when we're working on all this stuff. The reason we're going over these types of things right now, and the reason we're going to go over, you know, the competition between insurance and a cash practice is not because you're in a cash practice or an insurance practice at this point. There are some doctors that are going to be listening that are, okay, and they've actually had this fight with themselves over the years. And they don't understand the difference between being able to make the decisions for yourself and allowing some insurance company who doesn't have any kind of an agreement with the patient or with the doctor to be able to make all the decisions for the patient, someone that they don't care for, they don't have any kind of emotional attachment to, they don't have any interaction with at all. They're making decisions for that patient's life, not based on what's best for the patient. It's based on, you know, a bunch of ones and zeros on a piece of paper with a decimal point at the end of it. Okay, and you've got a nurse out in Idaho who probably has never seen a patient. She may not be in Idaho. Some of them are in Washington or Wisconsin, and some of them are in all the other states in the country. But you have these doctors that are sitting around also, and they're getting paid to cut claims and to reduce reimbursement. And along with this, and this is the other thing that's going on, in 2008, 2009, when Obamacare came in, I started telling doctors that, you know what's going to happen here is they're going to use the Medicare model as a whole, and they're going to pull that thing all over the rest of the insurance carriers and the rest of the insurance companies. They're going to use that same thing to dictate what they actually have to pay for. And you know what they're doing now? They're doing exactly that. You know, I talked to a doctor shortly ago, just a couple weeks ago, and this guy is out in California. And the interesting thing about it is his reimbursement is less than what we were being reimbursed for in college. Okay? His reimbursement for him to actually see a patient, and this includes any therapies that he wants to do, okay, is about $25. That's if they're in an insurance company. But he said, you know what? I can't get out of that model because, you know, the volume that I see is at least helping me cover my overhead. You know, Medicare wasn't put together for people to cover overhead. It was actually put together to limit the federal government's liability so that they could actually pay as little as possible to the doctors to force them to treat patients that don't have any motivation to get well, number one, and they have an entitlement to actually do whatever they're told by the federal government. That's it. So whether you like that model or not, I don't care who you are, I know that what we do is worth an awful lot more than that. Mm-hmm. And when we talk about this during the course of the next couple of days, we're going to talk about not only the value behind what we do, okay, but the importance in understanding how valuable what we do is. You know, it's interesting. I've had access to chiropractors for really since I was a little kid. And something I found funny is I know a doctor. I know him, you know, pretty well, and this guy was a great doctor. Okay, he was fantastic. He was an extremely intelligent guy. In fact, he taught gross anatomy for a while at one of the Big Ten schools, and he also taught anatomy at one of the chiropractic colleges. Really a smart guy, very intelligent, and in fact, he was a great teacher, I guess. Okay? He was a great teacher to teach those things. The interesting thing was that he thought that it was a lot more important and a lot more valuable to work on dead bodies in a gross lab than it was to work on live bodies. And the funny thing is, we all probably know somebody like this, but he was also the person that no matter what family gathering he went to, he'd always pull his thing out of the back, out of his trunk, his table out of his trunk. He'd have everybody line up, and he'd start adjusting people. Okay? And the thing is, don't get me wrong, I know the value behind what we do, and I know the fact that that can actually have a profound effect on every single one of those patients' lives, or one of the people's lives. But at the same time, every single time he did that, it diminished the value in his own mind of what he was actually doing. And so what happens with that is, instead of me sitting down with you when we go over all this stuff later on and explaining to you what your problem is and what we need to do to help, I'm sitting there going, oh shoot, you know, Not really sure what this is worth because I just did it for my whole family. They didn't charge them anything. They didn't even bring me a drink afterwards. I think they didn't even give me a glass of water. Okay, but the thing is, and none of them actually really valued the service he was giving, and so he devalued the service, not only in their minds, in his own mind. And when we start to understand this, we start to look at the value behind what we do, the fact that we can change lives, that we can help people avoid not only needless and unnecessary surgeries, but needless and unnecessary medications, which is what I've dedicated my life to doing, to helping people avoid needless and unnecessary surgeries and needless and unnecessary medications. And there isn't a day that goes by that I don't tell patients that. When they ask me why I do what I do, that's why I do what I do. And I want to make sure that they understand how important the value is in what we do. But as we go through this and we look at the best healthcare practices, what we're looking at is for best healthcare practices, we're looking at what's best for the patient, but along with that, for what's best for the doctor as well. And that's getting the best possible results. And this is the reason that we go through the philosophy about what we're doing right now, because unless you understand how important it is to go over the philosophy and understand why we do what we do, unless you understand that, then what happens is over time you start to go, this is really going to be an easy one. I could probably walk into the room and this patient's going to get better. And I've had that happen. But at the same time, what we're doing is vitally important for that patient's care, and we need to make sure that we understand it. Okay, so as we look here, as far as insurance practices versus a cash practice, okay? Insurance practices, you are listed in a book to be a provider, okay? And they get patients driven to them that way. From a cash practice standpoint, we're advertising basically to build our reputation as a specialist. And this is something that's vital, I think. This is the reason that we handle the things that we do the way that we do, and this is the reason I look at marketing the way that we do. When we're marketing what we're doing here, we're marketing the doctor. And I think that's very important, because if we're not marketing the doctor, then we're marketing someone else or something else. And our reputation is actually something that does not only precede us, but it also defines us. That's the reason that I'm such a perfectionist when it comes to what we're doing with patients. The funny thing is, I was talking with Michael a little bit ago, before we got started with this, and he said, the funny thing about you is that you are really pretty much a perfectionist when it comes to this. And the reason I'm a perfectionist is because I want to make sure that I'm doing the best possible job I can for the patient to get the best possible results. When we've had Dr. Sullivan here, he's been working with us. He's been learning the program, learning to function inside of my type of a practice, as opposed to, someone who's been practicing for a long time and who doesn't follow all these things. And as far as films are concerned, or x-rays, all of my films go from here, as soon as I'm done shooting them, as soon as I'm done making films, they go from here over to a place called Summit Radiology, which is at one of the hospitals here around. And they're read by the medical radiologist for pathology, okay? And the funniest thing about this is I actually have the system that we have is actually better than what they have at the orthopedic facility across the road, as far as the results, the films that we get, the pictures that we really, the quality that we get from our films is that good. They're fantastic. And as I was training him to do things, there were a couple of films that he was having trouble doing, okay? And my reputation is so important to me that, as we were doing this, finally I had to look at him one day and I said, look, man, if you're going to take films like that anymore, you're going to put your own name on them, so that when they go over to the radiology place, we're making sure that they don't think it's me that's actually taking these films, because they know that my films are actually as good or better than most of the imaging facilities around here. The reason I tell you that is not because I want you to say, oh, he's great with x-rays. No, it's because that's the way we address everything. We want to make sure that everything we're doing is working to build our reputation. Whether it's the way that we address patients, the way that we speak with patients, the films that we offer, and the results that we get, okay, they're all important. They're all vital. Along with that, patients don't come to insurance-based practices, and again, not only if they're not listed in the book, okay, but if they're not considered more or less a preferred provider. Okay, so the patient is in control in that situation. And in my office, the patient comes to us at our own terms. The patients that come to my office know that we handle patients on a prepaid case fee basis. They know, generally speaking, because everybody's seen our advertisements over the years, but they also know at least 1 to 5 other people who have been here, and they know that we're going to get great results. And that's something that's part of our reputation, and it's something that we've worked very, very hard to build. And it's something that you darn sure can't neglect later on. Okay? Insurance-based providers do have to pay or collect deductibles and co-payments and things like that. So they are collecting some money from the patient, but then along with that, they have to worry about the reasonable and customary values that the insurance carrier decides are worthwhile for that doctor. So no matter what, when you send your claims off to these guys, they're going to actually base it on what they think is normal or what they think is usual and customary, and that's generally between 50 and 75% less than what you're normally charging. Obviously, the insurance company just handles fees or determines the fee structures on those. In our situation, we can just determine the fees that we believe are necessary for the patient. You know, it's interesting. I talked to my dad all the way through my practice and all through my practice history. And my dad ran pretty much a prepaid case fee chiropractic practice back in the 70s and the 80s. And he told me at one point that he got a call from an insurance commissioner and said, well, you did this, this, and this. And he was doing all kinds of wild stuff way out there. He was way ahead of his time when in working with patients. He was really a visionary. And they called him and they said, well, Dr. Bush, we want to know what your charge for this was. Why did you charge this amount? And he said, well, that's, you know, first of all, I'm not an insurance-based doctor. I'm not part of your network or anything like that. So it doesn't matter really. And they're like, no, but the fee that you were charging, and this is back when people were charging between $2 and $14 per adjustment. You guys remember? Have you ever heard of these stories?
Yes.
Okay.
Yes.
So these stories are $2 per adjustment. Okay. That was the way that they were in the 60s and the 70s, and even in the beginning of the 80s, I think they were $3 to $5, and then they had more insurance coverage and stuff like that. And so that stuff began to grow. At the same time, the insurance company called him, and they're like, well, we've never seen fees like what you're charging. And he was charging $1,000 or a couple $1,000s at the time for his treatment. And they said, we just want to know what it is that you're charging for that. And he said, well, basically I was doing this type of a treatment, da-da-da-da-da. And they said, and he said, is there a problem with that? And they said, well, no, there's no problem. Obviously, you can charge whatever fees that you deem necessary because you're not part of our group, but we just wanted to find out what you were charging for that. And what kind of results you're getting. He said, well, I get excellent results, and went through that whole situation. And it was one of those things that when you start to look at, you start to realize that the insurance carrier is there not necessarily for the patient's best interest. It's for their own interest. Okay? So when we look at all this, we have to make sure that we understand that. Again, fees are cut significantly by the insurance carriers, and we don't have to deal with that. I do talk with doctors every day. I talk with a couple of friends of mine who, when we start to talk about our reimbursement, and they're absolutely astounded at the fact that we don't get our fees cut. And that they do, and in many cases, they sit around and they go, well, there's nothing I can do about it. I've been a part of this group for so long, or this network for so long, there's absolutely nothing I can do to change it at this point. Obviously, along with that, there is another negative that insurance carrier types of doctors have to work with, and that's that they actually have to wait for payment. Okay, as far as treatment is concerned, when I sit down and I go over a treatment plan with a patient, they're gonna when we sit down and go over their care, they're actually going to take care of it right now. Okay, we've talked about prepayment in the past. As far as prepayment is concerned, when I go over a treatment plan with a patient, whenever a patient asks me, or when I'm done with an initial consultation, I sit down with them and I explain to them that I do things differently than anybody they've ever seen before. Before I begin any care, we're going to sit down and talk about what the problem is and what we need to do to help. We're going to talk about how often we're going to see you, over what period of time, the expected outcome and any fees for the entire treatment. Patient's like, really? You're going to go over all that for me? You know, I heard that you went over a lot of things, but I didn't realize you were going to go over all that for me. And the answer to that is, yeah, we're going to answer all your questions. You're going to know exactly what we're going to do and what our expected outcome is before we actually begin anything. And when the patients understand that, it's a very important thing for them because they start to understand that their care is more than just a couple of codes in a book. Okay, their care is more than just the idea that, hey, I'm going to have to listen to these people over here who don't really care about me. I'm going to have to do what they say. You know, the funny thing about it is there are a lot of people out there who like to be told what to do. I'm not one of them. In a lot of cases, the patient actually discontinues care when their insurance company is done with their coverage. And this is something that's very important. There are a lot of people who are limited by number of chiropractic visits. Okay, they may be allowed 10 or 12 visits a month or a year. Well, I'm not sure who came up with that. I think it's probably the ACA that said, well, that patients just need 12 visits a year and that's all they need. Don't need anything else. Well, I haven't seen one patient ever that just really needed only 12 visits a year. You know, my family, I don't treat that way. I don't treat myself that way. Okay, I don't treat my wife that way. If I did, she'd kill me. But along with that, you have to understand that if we understand what the patient actually needs and we can convey that to the patient, we can make sure that we go over this in a manner that's informative and not threatening so we can make sure that they understand exactly what we're doing. You know what's going to happen? The patient's compliance level does go up, doesn't it? And they're not going to discontinue care because all of a sudden their insurance company said, hey, that's all we're going to do today. We're not going to do anything more for you. Unfortunately, that's something that happens as soon as insurance runs out. And we see that. We've seen it for years. I'm sure that you probably have seen it even in your own office. Where, you know, Medicare, they give us 12 visits a year. If we have an exacerbation, maybe something else is gonna help with increasing that amount. You know, the funny thing is, I had a patient, she was 106 years old when she passed. And she was actually a really funny lady. When she came in for years. I think we saw her for the better part of 20 years. When she came, she obviously wasn't 106 when we first started seeing her. But when she came in, she wanted 3 things from me, okay? She wanted a hug, she wanted an adjustment, and she wanted to tell me a dirty joke. Okay, and she told me some really dirty jokes that would make a sailor blush. But it always made me laugh. But she understood one thing, and that's that what you need in life isn't just what they tell you. Okay, what you need in life is actually what you need in life. And when we start to understand what we really need and what we really want, you're willing to do that if you understand what the investments are. Funny thing was, we used to have to ask her for, because for Medicare guidelines for active treatment, you have to have done something that would have exacerbated your condition or caused it to be a little bit worse for you to warrant some type of reimbursement from Medicare, right? She said, well, yeah, I'm familiar with that rule. Actually, she kind of yelled because she had really bad hearing. And to make a long story short, so I started asking her that question, and after a couple days, she looked at me. She goes, honey, I'm 106 years old. It's an exacerbation for me to get out of bed every day. Okay? So everybody has different things that affect them. It can be emotional. It can be physical, emotional, or even chemical stresses. Those are all the things that are actually playing a role in what we're seeing, what we're doing. And so when it comes down to those things, we have to understand that there's not a limit that some guy sitting in a cubicle somewhere can actually sit down and go, well, this is all your coverage is, and you don't need anything else. And that's one of the big differences between what we're able to do by going over treatment plans with patients, by explaining to them what their problem is, explaining to them what their expected outcome is. That's one of the reasons all this stuff is important. So we want to make sure that we're actually doing that. We also want to make sure that the patient isn't necessarily influenced by their insurance company, but that they're influenced by us and our staff. You know, your staff is a huge motivating factor here. One of the things that we have to make sure that they're doing is always building our reputation. We talk about reputation building from advertising and marketing, but reputation building in the office is absolutely the most important thing that we can do. and one of the most beneficial things that we can do. When we talk about reputation building as far as our staff is concerned, you know, one of the things that our staff here says is, you know, Dr. Bush really does love very challenging cases. Dr. Bush wouldn't have accepted you for care if he didn't feel he was going to get outstanding results. You might want to write that down. Okay, Dr. Jones. Dr. Jones doesn't accept patients unless he feels he's going to get outstanding results, right? And I know that you, as well as I, always like challenging cases. Dr. Bush isn't like any other chiropractor out there. In fact, he gets results that are really second to none. In fact, he doesn't really have any competition in this area. In fact, the people that Dr. Bush is in competition more than anything aren't other chiropractors, because they're not even on the same level as he is. He's more in competition with the orthopedic and the neurosurgeons. When you start to realize that over half the people I see have had at least one failed back or neck surgery. Again, they've seen 1 to 5 chiropractors. They've had 1 to 15 epidural injections. They've had physical therapy. They've literally had every other treatment that's out there. They're on medications. In a lot of cases, they're on some type of a narcotic or an opioid type of a medication. Those things are being limited as far as use now, and one of the biggest reasons for that is because a lot of their patents are running out and they can't charge for them anymore. So they're putting these patients on different medications that are not only more expensive, but along with that, they have bigger side effects. Okay? The side effects that the opiates had, if they took too many of them and they drank, they'd probably die. Okay? The medications that they're using now, okay, things like the gabapentin and Lyrica. Gabapentin was actually developed as an anticonvulsant. Did you know that? Okay, they had it. They used it for people with epilepsy. It's easy for me to say, right? Epileptic seizures. You know what the biggest side effect of gabapentin use is? Epileptic seizures. All right. Along with that, it also causes memory problems. Okay, it causes fatigue. It causes all kinds of different problems. The side effects that they're giving you these drugs for are all worse than what you're taking them for. Okay, so when you start to realize that, when we start to look at all this stuff, we start to understand, okay, there is a different motivating factor there. A lot of the insurance companies are aligned with the pharmaceutical industry, right? And so we start to look at it from that standpoint as well. When you start to realize that the pharmaceuticals are controlling the insurance companies, and the insurance companies are kind of controlling pharmaceuticals as well, you start to realize this is really, really a big business there. So we want to make sure that the patient's not influenced by their insurance company, but the patient is beneficially influenced by us. Again, we're using good control over people to make sure that they make the right decisions in life so that we can get the best possible outcomes. Obviously, with insurance networking and stuff like that, and I don't know how much you do or much the doctors out there do, there's a hell of a lot more paperwork to deal with insurance networks as well. I mean, first of all, we have to handle making sure that we got our notes. We always make sure we have great notes anyway, but you know, you have to print off your notes and send them off to these guys to make sure that they can actually review your notes. Again, to make sure that you can get more care paid for. But then again, you have to stop care to make sure that you get approval from them to let that patient that you made all this headway with. They have to sit around and wait for it. But then along with that, you have to run through that whole deal of making sure you get your records and everything else around, mail them to these guys. It takes a lot more work. It takes a lot more office staff and everything else. Obviously, what we do is less paperwork. Again, you got 10 to 20% more paper or more overhead in working with the insurance carriers, and that may actually even be larger than that at this point, because that 10 to 20%. Now you also have to include filing fees, and at the same time, though, we want to make sure that we understand this, and that's that. Okay, so with a lot of the different clearinghouses and things like that, okay, we have a lot more costs to make sure that we get these things or these claims paid. And so, first of all, they're deducting the coverage that you have. They're deducting your reimbursement, so they're decreasing that from 100% down to 75 or 50%, or 50% or 75%. And then along with that, we have to pay to get those claims cleared. And then we have to pay a percentage of that. We don't have the increased overhead that we deal with that, okay? Collection department, I don't have one. I'm certainly glad about that. So we don't have that overhead. The potential to be audited or have large refunds requested by these different carriers. You know, the amazing thing about this, and I've heard this for years, I never really completely understood it, but as far as these carriers are concerned, they can go ahead and they can approve your treatment, all right? They can actually take a look at all your stuff, all your notes, all your records and everything else, go over all of those things that you've actually provided for them, and they can actually go ahead and pay it. So they put the money in your account, and then a couple weeks later, months later, or even maybe a year or two later, they go, you know, I'm not sure what Dr. So-and-so over there is doing. I think we've been paying him too much. So I want to go back and review all of his claims and find out whether we've been paying him too much. And what happens is, and they've done this in a lot of cases, where they go back through and they say, well, we want to see all your files for this, this, and this. They actually go through it all, and you know what they find out? They find out that they may have overpaid you on 1 or 2 or 3 claims, and then they extrapolate that to all the claims that you've given them over the course of a period of time, and they request these really big refunds. Okay, it could be tens of thousands of dollars, it could be hundreds of thousands of dollars. And the thing is, this is something that we're all nervous about, we're all scared about. I'm going over this with you guys, not because I want to scare anybody, but I want to make sure that we're reinforcing the idea behind what we're doing here. I'm repetitive with a lot of different things, and the reason I'm repetitive is because the more that we hear them, the more often, or the better it is for us from a memory standpoint. And along with that, I'm also talking about a lot of things that you already know. Okay, even some of the doctors that are going to be listening on this video, there are a lot of things that they already know, that they've already heard, they've already been in contact with. We've all been in contact with. But that reinforcement, some of the best lectures I've ever sat through were things that just reinforced what I already knew. Accidentally or erroneously billing an inappropriate code. What's funny about that is, even if it's an error and it was done by somebody else, you're responsible for it, right? And so that's not only the reimbursement thing where they come back and ask for it, but that's also the thing where they... Thought I was done with that. Where they actually come back later on and they say, hey, by the way, we don't think it was just an error, we think it was fraud. And so as opposed to just requesting a refund, we want to come after you for something now. We don't have the problem with that. In fact, at one point, I had my records requested. This is years ago. I knew I didn't have to actually produce them. I did anyway, because I just wanted to see what kind of a response that they had. And after I gave them about 800 pages worth of records, because you know we just printed everything out of our system, and they just sent me a letter back that said, well, we've reviewed your system, you know, you're doing everything the way that you're supposed to, but we would request that you use this code as opposed to this code. And we made that change, and we've never had any problems with it. But the reason I did it was because the doctors we were working with at the time, I wanted to make sure that I knew, first of all, what they were going to be going through, and second of all, wanted to make sure that we had the proper answers for them. So that's something that we don't have to deal with at this point. You know, I'm not contracted with any insurance provider. I never have been. Okay? I've never been contracted with anybody from the time I started in practice 27 years ago, and I'm not going to be from this point forward in my life. I've had them try, in a couple of situations, to force us to become contracted with them. I even had somebody fill out at one point where I got a notice from an insurance carrier that somehow I had surprisingly or miraculously applied to become part of their network. Kind of strange, huh? Especially because I never did. So somebody along the line had gotten a lot of our information. Obviously, we got out of that pretty easily because it wasn't us. But at the same time, that's something that they do, because when they start to realize that you have people that they want to come to see you. But at the same time, people are willing to invest in themselves, and that's something we have to take a look at. Insurance carriers, their insurance practices, there is a lot more stress. Okay, there is a lot more work, and you are dependent on that insurance carrier. They control everything in your life at that point. I've got a friend, a really good friend. He ran a really, really big insurance-based practice, multidisciplinary, multiple offices and everything else. And what he found is that those insurance companies don't really like to give chiropractors millions and millions of dollars. They just don't. And so what they did at one point was they decided, you know what? We're going to put this guy on a special type of a prepayment review thing. And basically they said, so any of his claims that came through for any of these offices had to go through a special audit before they would pay him. The thing about this audit is it could take 6 months. It could take 6 years. And the thing is, it will. And the thing is, you know, when they're the ones who are holding the checkbook, they actually have your life in their hands. And so the thing about this is, we want to make sure that we understand that and that we're not a part of that at all. What this allows us to do is it allows us to be completely independent. Okay, we do have less stress. I've got a doctor that came through this program years and years ago. He said, you know, the funny thing about it is he was an insurance-based carrier years ago as well. He said almost every single night when he went to sleep, he was worried about the billing and making sure that nobody did anything inaccurately. He said he didn't sleep well for the better part of 10 years because he was always concerned about the fraud that could have taken place, not because he did anything intentionally, but because something that was unintentional was done without his knowledge. And when we start to look at things like that, that's a pretty big burden to carry every single day, right? What do they say? Stress kills. Okay, stress kills. Stress causes things like cancer, heart disease, okay? It causes all kinds of other marital problems. Stress can be a huge factor in addictions and things like that. And the thing is, that's one of the reasons that many people in the medical community as a whole do have different types of addiction problems as well. Okay, it's because of the stress that they carry, because of all the things that they have to do to provide for their staff, for their families, and everything else. And then along with that, they got that other stress over here of, holy smokes, did I do something wrong that I don't know about? It changes your life. It changes the way you're doing. Obviously, along with this, we also have, so as we're getting down to the end of these, I think you guys are kind of seeing the reason I'm laying this stuff out is to make sure that we all understand how important it is to make sure that we're working on a cash basis with our patients. Very often the patients that come in just based on their insurance, okay, there is some ill will toward the doctor that way as well. They always walk in skeptical of the doctor, that the doctor is only going to do the services he's going to get paid for and doesn't have any desire at all to help that patient get well. That's not what they're there for. They're just there to bill. I had another friend years ago, and I tell stories along the way for a reason. And that's because I think that it's a lot easier to absorb the concepts that we're talking about through stories, number one. And number two, it's a lot easier to personalize them because we all know somebody who's had a situation like this, or it's very easy to put yourself in that position and go, wait a minute, that makes a lot more sense. But I had another friend who, I guess he was more of an acquaintance than anything else. But over the years, I've seen a lot of patients that had been to his office. And one of the funniest things that happened to me one day, and I knew that this guy had some billing issues, but one of the funniest things that happened to me one day is I sat down with a new patient and I started asking him questions about, you know, what he was doing, who he'd seen in the past. And he told me who he'd seen in the past. And I was like, oh, you know, obviously you're here for a reason, but what, you know, how come you're not seeing him anymore? Because I know he's a pretty good guy. And he said, well, he said, I went over there until I started getting all these things in the these things from my insurance company in the mail, which were billing for codes and for treatments that I never received on days that I was never there. Okay, that happens a lot. It happens a lot more than you'd ever understand or know. And I've talked to doctors on the phone who have actually had similar situations where it may have been somebody in their office that was billing errantly. But there are some people that were doing it intentionally. They didn't think they were going to get caught. And the thing about it is, I know one thing, and that's that if you're never doing anything like that, you're never tempted by anything like that, you're never going to have to worry about that. Okay, so we don't have to worry about that. And again, it's a better working environment for the doctor and the patients. The patients know I care about them. You know, when they've actually made that investment in their care, and I jump all over them because they've been missing their appointment. Okay, when I let them know that I'm mad at them because they're not making their appointment, they're not doing their exercises, they're not following the recommendations, they're not taking the supplementation that we talk about. When I get mad at them because of that, they know that I'm mad at them because of that. It's not because they're sitting around going, well, shoot, this guy just wants to make sure he still gets reimbursed by my insurance company. That's not what we're there for. We're there to make sure that that patient gets the best possible results. And you know what? The only way we can do that is if that patient is actually following the result or the recommendations that we give them. And that's the reason that we go over things the way that we do as far as from a cash standpoint. And that's the reason that we get the results that we do. And along with that, you know, as far as treatment is concerned overall, the patient does really appreciate it, I think, when you really actually do care about them. Okay, and my staff understands that we care about the patients. And they all understand that they play right along with this. They have to be part of the whole program. If they don't care, they don't stick around here. And so that's one of the things that we make sure that they understand. And that's, again, why we have such a great deal of success. Again, we get a higher success rate, higher percentage of commitment. You know, overall, we get results that in many cases people don't think are really possible. You know, what we're going to talk about with the DRS program and with what we're doing with spinal decompression in particular, you know what the success rate for this stuff is from a surgical standpoint? Okay, it's very, very low, right? You know how many people there are out there who have had epidural injection, or they've had surgery, because you know what? Once you get surgery, you're going to be better, right? Everybody thinks, oh, once I have surgery, I'm just going to be better and everything's going to be back to normal. It's going to be fantastic. You know, life's going to be peaches and cream, cherries on top, and everything else. We're going to be great. It's going to be fantastic. I'm not going to have any more cares in the world. Everything is just terrific. Okay? Well, the funny thing about that is, why is pain management one of the biggest parts of healthcare? Well, because that's not the case. And we know, and again, we're going to talk about statistics and everything else. I'm going to show you the literature tomorrow. But we know that as far as surgery is concerned, really they have about a 20 to 30% 5-year success rate with back surgeries. Okay, that's not my numbers. That's theirs. We know that with each consecutive surgery that they have, their success rate drops dramatically. And we know that once they have those surgeries, they can't be undone. And we know that their only real options at that point are medications. And so the biggest thing we have to deal with here is, you know what? If we understand that that's one of the largest and fastest growing parts of healthcare, our competition really isn't that big. Because you know what? There are these pain management guys all over the place. We're dealing with patients that they don't want to see. We're dealing with patients that the medical community as a whole doesn't want to see because they don't have an answer for people with chronic pain. We're dealing with patients that most chiropractors don't want to see because they don't really have an answer for it either. We're dealing with patients that the medical community as a whole doesn't want to deal with because they have chronic pain, and in many cases, a lot of them have become addicted to different drugs. There isn't an option other than the medications, and basically their quality of life has gone through the toilet, and it continues to get worse. And so the idea here as far as treatment, as far as what we're working with these patients, all of these patients, they all have really chronic problems, right? So if they have really chronic problems and their only option is to live with that chronic pain, okay, when you think about it, okay, once they've had, okay, so if you have chronic pain, you've got 3 options, right? Number 1 is to do nothing. Number one is to have surgery, and number two is to have medications, right? That's what the medical model is. That's it. Either live with it, have surgery, or medications. Well, once when they've had the surgeries, and that didn't work, and I've actually had patients that have had between 1 and 14 surgeries. The guy that had 14 surgery, I had to ask him, after the second one didn't work, what the hell did you have another one for? He said, well, they told me it was going to get better. You know, the funny thing about it is, it didn't get better that time, or the next time, or the next time, or the next time. And then we're starting dealing with things like with scar tissue, chronic inflammatory processes. We got to deal with infections in a lot of cases. We have to deal with biomechanical alterations, okay? Then we also have to deal with a lot of the psychological aspects of their problem, okay? And when we get into all this, when we're dealing with chronic pain, psychology is a huge part of what's going on. As we mentioned a little bit ago, these patients do become attached to their pain. It's like a friend they can always count on. It's a bad friend, but they can always count on them, right? All right, any questions about anything to this point? Yes.
I got a bunch, but I wrote one down.
Good.
Going back to the insurance versus cash. If you're a cash office and the patient is taking their super bill from you and remitting the insurance, remitting to their insurance on recognizance, do you still have audit concerns?
No. Basically, the whole purpose behind all this is the patient is, we have an agreement with the patient. The patient has an agreement with our insurance company, okay? That being said, if the insurance company asks me for records, we do go ahead and get those records for the patient and get them sent off to their insurance carrier. At that point, though, we're not necessarily, there isn't anything we can be audited for. We're not accepting assignment for the patient, okay? We want to make sure that our records are clean and clear and concise. But at that point, what we do as far as remittance and everything else, and Jennifer's going to go back to this later today, we do verify insurance for the insurance company or for the patient, okay? Which means my staff calls calls the insurance company and says, "This is what this is your patient's name. This is what their insurance card is. These are the types of things that we're gonna bill for, or that they're gonna submit payment for. What kind of coverage do you have for that, or do you have coverage for that? And this is in and out of network." Because we're out of network, we don't have to comply with a lot of the regulations that they have. We also have the patient initial and sign something that basically says, "I understand that you have checked my insurance coverage and that you've given me an estimate of what it may or may not cover. However, this is obviously no guarantee that you have any insurance coverage at all. That's something that the insurance company is going to come back with you later on." Okay, so they have to wait for their reimbursement with that. Other questions?
That was the main one from that. I just when you said that, I had a concern that there was still a possibility of being forced to reimburse the patient if the insurance company that they're dealing with was not satisfied with your paperwork.
No, it's a great question, and actually, this is something that's kind of funny because, and I'm going to have you discuss this with Jennifer or even Rachel when she comes down. The funniest thing about this is we have insurance carriers that are all the time trying to send us the little credit cards now. They're doing it with credit cards now, where they send you a credit card and they say, "Well, this is what this is what the patient was supposed to be reimbursed, but we're sending it to you instead." Okay. We actually send those back to the insurance carrier with a note or notification that says, "As far as this patient's concerned, these are the treatments or whatever we've let you know in the past, and we did not accept assignment on this patient. Any reimbursement is due the patient." Okay. The reason that they were sending it back to us, though, I think, is to get in our bank account, so that they can basically say, "Well, we reimbursed you, so now you have to reimburse us," as opposed to them going after the patient. Okay, so that's the way that we work. Don't even work around it. that's how we work with that.
Okay.
Does that make sense? All right. Any questions to this point? Any other questions?